सौरव, सॉरी यश।
No problem. I'm okay. I'm comfortable. I have enough time. No problem at all.
नो नो।
Yeah, I know. I understand.
These guys have been doing this for such a long time, and then
Happens. Happens.
हेलो सर।
Yeah.
क्या लगा रखा है सौरव क्लास के बीच
सर
में? हाँ,
सर नहीं सर, ये जूम जूम से इधर से लाइव हो गया था, लेकिन वो फिर से ऑफ हो गया सर, इसलिए।
अभी आ रहा है नहीं आ रहा लाइव स्ट्रीमिंग?
हाँ, अब लाइव हो गए सर, लाइव हो गए अब।
क्लास स्टार्ट कर सकते नहीं कर सकते?
हाँ, स्टार्ट करो सर।
Okay.
We'll
So
have a
the
meeting about this after the class is over, okay? Yes, please carry on. Yeah, sorry.
yeah. No problem. No problem. So the background of the talk, sepsis. In sepsis, inflammation is a necessary evil. We understand we need inflammation to ward out the necrotic debris, to ward out the bacteria and the insulting agent. But role of inflammation in sepsis pathology is a double-edged sword. Various drug trials for sepsis have been a catalog of failures. That is why we often call clinical sepsis as graveyard of clinical research. But we have learned good lessons what not to do in sepsis from all these trials. We understand there is hypercytokinemia, but we also understand there is CARS phase and there is severe immunosuppression, and more patients suffer, have mortality and morbidity during the phase of immunosuppression rather than the SARS phase alone. What we tend to desire, we cannot achieve perfect immunohomeostasis. What we desire is to bring the patient to a lesser degree of immune disarray, nearest to the baseline, which is possible. Immune response in sepsis is uncontrolled. We want a controlled response ideally. Self-augmenting, generalized. If there is an infection in my finger, I should have a localized response. But at times it becomes generalized. It should be specific, but at times it becomes non-specific and affects the bystander organs also. Why do we need these immunomodulatory therapies or adjuvant therapies? The concept of these adjuvant therapies has been bought from the field of oncology. We understand oncology had high mortality and we need to have new drugs, adjuvant therapies, which can decrease the mortality. The same concept has been brought to sepsis because despite of best interventions, despite several phases of guidelines, the mortality has not come down drastically. This is from early 80s to early 90s, where several drugs were tried, but again, the mortality remained almost the same. And there has been little change in mortality in last 35 years, despite more than 300 clinical trials of various immunomodulatory agents. The mortality remains very, very high, and this is just the tip of iceberg, the numbers which we know. This is the reason why we need immunomodulatory therapies in sepsis. Various therapies have been tried: anti-LPS serum antibodies, anti-TNF antibodies, IL-1 receptor antagonists, IVIG, activated protein C, but nothing has shown a significant survival advantage in these therapies, especially the big data analysis. Does having one primary treatment for such a complex disease make sense on the surface? Do we think there can be magic bullet for a complex disease like sepsis? On the face, this might look good. This is what we desire, but this is not how the real biological world works. There will never be a magic bullet for any disease for that matter. These drugs we already discussed, antithrombin, methylprednisolone, high dose, but all of these although showed some benefit in small groups, but big data analysis failed most of these therapies. This is the molecule tifacogen. which was probably launched somewhere in 2003. A 17-country study of patients found no reduction in death from the disease and, on the contrary, linked the drug to an increased risk of bleeding. Eritoran, this was thought to be a blockbuster drug. The trials began in June 2005 and was in the last stage of patient studies to seek the regulatory approval. It studied patients and compared mortality after 28 days of hospitalization, and they said its experimental drug to treat severe sepsis failed to save more lives than placebo in a final stage study. Drug Centoxin, this was also thought to be a major blockbuster, but a multicentric trial again failed to show any survival advantage. On the contrary, the death rates among the patients who received this drug Centoxin was higher than the control group. And this was probably the last major kill for sepsis trials. No exception for Agenix as sepsis claim another hopeful victim, Telectoferrin. This was probably Dr. Anand Kumar's trial. Agenix announced that it was halting the phase 2-3 OSS trial of its oral immunotherapy Telectoferrin, which is the recombinant human lactoferrin for severe sepsis. Although we used Zygris for some years, but the bigger trial, the second phase of the trial, we were also part of this trial, failed to show any mortality advantage, and the drug was off-shelved after being 10 years on the market. Shock Progress 2 trials failed to show any benefit. So there have been various trials: intensive insulin, Zygris, antithrombin 3, Eritaran, Cytofab, endotoxin removal, and the list is endless, and we are still trying to find the right drug. So sepsis remains the largest unmet ICU needs in terms of immunomodulation. Why? Because it kills. Second, the magnitude of sepsis is huge. We have sepsis everywhere, in the wards, in the hospitals, in the community. And sepsis continues to kill a majority of our patients who have not been admitted with an infective etiology. Why don't we have any magic bullet in sepsis? Because the presentation is myriad, heterogeneous, and dynamic disease. There is redundancy and pleiotrope of mediator. Redundancy, we mean if we block a particular pathway, another pathway will take over. This means monocausal treatments are not going to work. By pleiotropia, we mean each mediator, each cytokine has some good effects, some bad effects. Although we know that particular cytokine, by virtue of the maximal good or bad effect, pro-inflammatory or anti-inflammatory mediator, but all mediators have some good effects, some bad effect, and some ugly effects. So it is oversimplification if we think that blocking a particular pathway, decreasing the levels of a particular mediator is going to cure our patients. There is no single lethal factor or process to target, and we do not know the immune status of the patient. There are more than 300 mediators of sepsis which we commonly know, and it is impossible to understand which phase of sepsis the patient actually is. It is most of the time our guesswork. So there will never be any magic bullet for sepsis. We should not be thinking about it. However, there have been lessons which we understood from all these trials, which we'll be discussing in the due course. Don't fire until you see the white of their eyes. Unless you see clinical benefit in a small group of patients, then in larger trials, and then the big data analysis also shows you benefit, don't start using these therapies except in the experimental scenarios. So don't be fooled with smaller popular guidelines or smaller articles or smaller RCTs published in even big journals. Those are happy ending trials, and let us gather good evidence before we starting it using left, right, and center. So don't act before you have some chances of success. In nutshell, for every complex problem, there is an answer that is clear, simple, and wrong. And same applies to sepsis. Do not be fooled with all this. Immune system is basically a black box. We do not have the right side of mediators. We do not even have a good biosignature panel where the combination of 3 or 4 biomarkers can tell us which phase of sepsis the patient is in. So what we are left with is, immunomodulation. We tend to bring our patient to a lesser degree of immune dysfunction. If you cannot stop the waves, we must learn how to serve these waves. This is the popular pro-inflammatory and anti-inflammatory cascade, which was first published by Roger Bones, and then various versions of the same, and there have been various additions to this. Persistent inflammation, persistent catabolism, progressive immunosuppression in this phase, and now we have been talking about post-intensive care syndrome, post-sepsis syndrome, which persists for days to months after the acute insult is over. So there is need for anti-inflammatory in the early phase of disease to ward off the infection, but there is also need of immunomodulatory therapy in this fixed or immunosuppression phase, because this is the phase which have the highest morbidity and mortality. We often only are fixed to this surge phase and we forget about CAS response, we forget about this immune suppression phase. So we need to focus on all phases in these trials. We need to have a multidisciplinary approach while tackling sepsis, hypoperfusion, hypotension, organ dysfunction. If we target all these interventions in the right way, then also the immune dysfunction decreases. If you target hypertension at right time, the endotoxemia from the gut decreases. So there are larger applications of this immunomodulation concept. What we promulgate is right antimicrobials, multi-organ support therapy, and immunomodulation. This we call the trident approach for sepsis. What immunomodulation remains a burning question, but we need to think about some immunomodulatory therapy. Critical care medicine essentially is organ support and give time to regenerate. We always talk about homeostasis. In context of sepsis, we talk about immunohomeostasis and bringing the patient to a lesser disarray of immune dysfunction. A busy slide I will read out for you. Is it hope or hype? Whatever it is a burning question and it is our desire, and we will continue fighting for a good immunomodulation for therapy in sepsis. The simple answer, do we require it or not? The answer is yes. But bigger question is what works and what evidence we have. Steroids has the largest body of evidence till date for immunomodulation. Various repurposed drugs and intervention have been tried. What, when, and where to use are still unanswered questions. Regardless of this, we should be aware of these therapies and should be using it in right context and build right evidence. Though the consolidated sets of evidence of the benefit of these therapies are yet to be established, the risk-benefit ratio is to be taken into consideration. Various immunomodulators are being used off-label with variable success to blunt hyperinflammation. We should not be promoting cult science. We need to look at risk versus benefit. At the same time, we need to look effect versus benefit. And approval in MAP or approval in oxygenation indices should translate into survival advantage. So effect is one thing, the cytokine levels coming down, but the benefit is the larger picture we have to look at. We also have to look at the side effects of all these therapies. Remedies are slower in their operation than disease, so we are taking a long time. And at the same time, the intervention or the therapy we use should not be harming the patient and have a larger mortality and morbidity because of this. The next important concept is thromboimmunomodulation in sepsis. Hemostasis is disturbed in sepsis. We all know generally a procoagulant state. Inflammation and coagulation go hand in hand. There is fibrolysis also at time decrease. Fibrolysis, this makes sepsis a procoagulant state. Hypoxia adds to the fire of inflammation and thrombosis. The extensive interaction between inflammation and coagulation contributes to the basic pathophysiology of sepsis. Coagulopathy associated with sepsis has long been identified as a clinical feature of disease. The crosstalk between coagulation and inflammation during sepsis warrants further investigation. There have been some trials like activated protein C, antithrombin, and various other molecules, but again, they haven't seen the light of the day. And we need to translate from bench to bedside, and this remains the biggest hurdle. We'll discuss briefly about some of these interventions. This is from British Journal of Hematology 2017. The role of heparin in sepsis, much more than just an anticoagulant. Agents that attenuate the activation of both inflammation and coagulation may improve the outcome in sepsis. Apart from the well-known anticoagulant effects of heparin, it also possesses various immunomodulatory properties and protects glycocalyx from shedding. Hence, heparin seems to be one promising agent, but the larger body of evidence till date has not supported this, and the surviving sepsis guidelines also do not support use of heparin. Heparin as an immunomodulatory therapy. Immunothrombosis plays an important role in early host defense against bacterial dissemination. Thus, the proper timing for anticoagulation therapy should be determined for sepsis, and the right dose also need to be determined. Regardless of this, we need to give DVT prophylaxis for all our patients with heparin or low molecular weight heparin as the situation warrants. General approach to immunomodulation is what we are going to discuss in the first part of the next slides. Non-selective immunomodulators, what we have and what is the evidence, and immune augmentation strategies. So these three headings it will be discussing about various immunomodulatory therapies. The general approach, the common things which we do in our ICU for septic patient, how do they immunomodulate the patient, non-selective immunomodulators, and immune augmentation strategies. The common things which we do in ICU. Appropriate early antimicrobials, optimize PKPD, source removal. If your endotoxin release is less with the right antibiotic, obviously the immune cascade will die off while will be decreased in the intensity. That is why right antibiotics in the beginning is important. Whenever there is bacterial lysis, cell lysis, there are various endotoxins which are released. That is why at times while we give the initial first antibiotic, we hit hard. And these endotoxins are released in high number because of the bacterial cell lysis. And this we call antibiotic paradox because all these endotoxins will have various cascade effect, hemodynamic perturbations, and other things. So the right antimicrobials, right dose, early source control, everything helps in immunomodulation. We understand gut-associated lymphoid tissue is the largest lymphoid tissue. Early enteral nutrition is the best way to immunomodulate our patient. Start enteral nutrition as early as the situation warrants. Immunonutrition specific therapy is arginine glutamine, no role. Steroids will be discussing in details. Albumin will be discussing in detail. Heparin again, no role in terms of immunomodulation. We need to prevent endotoxemia from the gut and the lung. Lung protective ventilation, less biotrauma, less release of endotoxins. How to prevent endotoxemia from gut? Early enteral nutrition, have a decent map, and many other interventions which we are all aware of. Going on to the surviving sepsis guidelines on various of these interventions. For adult patients with sepsis or septic shock who cannot be fed enterally, we suggest early initiation of enteral nutrition, although say 72 hours. We generally start enteral nutrition once the norepinephrine requirement is reasonably moderate range or our resuscitation phase is over. The early administration of enteral nutrition in patients with sepsis and septic shock has potential physiological advantages related to maintenance of gut integrity and prevention of intestinal permeability, dampening of the pro-inflammatory response, and modulation of metabolic response that may reduce insulin resistance. Non-selective immunomodulators, corticosteroids, vitamin C, antibiotics with anti-inflammatory properties, erythromycin, and various other agents, activated protein C and thrombomodulin, bioactive adenomodulin, and extracorporeal blood purification therapies. We'll be briefly touching on few of these therapies. Activated protein C, thrombomodulin, no big evidence now. Adenomodulin, again, no big evidence. Vitamin C is one molecule probably where a lot of work is happening, and we should be looking at the papers which will be coming up. Extracorporeal blood purification will be discussed in details. immune augmentation strategies. This was non-selective immunomodulators. Now, this is immune augmentation strategy. We are trying to augment the immune response. Immunostimulatory cytokines and growth factors, granulocyte macrophage colony stimulating factor. No role in sepsis in general, but if the patient is neutropenic, patient is having neutropenic sepsis, or other indication of GM-CSF, we need to use, but not as a general thumb rule for sepsis. Interferon gamma, again no role. Ulinastatin, thymosin alpha 1, again no role. Immunoglobulins, adult population, generally there is no roles. IgM-rich immunoglobulin, there is some role, especially in pediatric population, which we'll be seeing in details in coming slides. Mesenchymal stem cells, no big role. Immune checkpoint inhibitors inhibit some of the pathways. Again, there's a lot of work which is happening on these immune checkpoint inhibitors, but nothing concrete as of now. Glucocorticoids. Clinical trials of steroids in sepsis yielded controversial results. The pendulum has been shifting to and fro. Some showing improved outcomes and others reporting no or even adverse effects. Therefore, current guidelines contain only a weak recommendation for hydrocortisone in septic shock. However, after this CAPE COD trial in severe pneumonia, patient with severe CAP who received hydrocortisone had a lower mortality rate. This brought and focus update about use of steroids in critical care medicine and the surviving sepsis guideline, which was published in 2024. What are the recommendations for steroids in septic shock now? There has been a suggestion to administer steroids to adult patients with septic shock. Initially, we were using when the norepinephrine doses were very high. Now, we started using it for all patients with septic shock. The recommendation is against administration of high dose or short duration steroid for adult patients with septic shock. So the dose remains 200 milligram in all patients with septic shock. Vitamin C. While initial studies suggested improved outcomes in sepsis, further studies could not confirm a beneficial effect. Many trials. Role of vitamin C in sepsis remains uncertain. It should only be used in context of RCTs or an experimental phase. Many studies are underway and probably there could be some success with this molecule. What does the surviving sepsis campaign guidelines say? They suggest against using IV vitamin C for sepsis or septic shock. A weak recommendation, low quality of evidence. Anticoagulants, the surviving sepsis guidelines make no recommendation regarding the use of thrombomodulin or heparin for treatment of sepsis or septic shock. Ulinastatin, on the global platform, there is hardly any significant evidence, but as many of our Indian colleagues have been using it, I'll shed some light on this. Acidic glycoprotein, a broad spectrum protease inhibitor. Because it's a broad spectrum protease inhibitor, it has a wide application, not only in sepsis, but pancreatitis burns and many other diseases. Japan, Korea, it is part of the guidelines, but the evidence is very, very weak to give any recommendation. And there is no mention about this molecule in surviving sepsis guidelines. There have been some studies with decreased mortality, but most of these studies, almost all of these studies had significant bias, and these were sponsored trials, so can be thrown into dustbin. Immunoglobulins in adults. For adults with sepsis or septic shock, we suggest against using intravenous immunoglobulins. This is a weak recommendation and low quality of evidence. While this is the pediatric surviving sepsis guidelines, which was published in CCM 2020. They also suggest against routine use of IVIG in children with septic shock or other sepsis-associated organ dysfunction. Weak recommendation, low quality of evidence. Although routine use of IVIG is not recommended, select patients may benefit from such treatment. Data from adult patients with septic shock also do not support a routine benefit of IVIG. Although administration of immunoglobulin M is IgM enriched immunoglobulin. It has more IgM compared to other immunoglobulins. And immunoglobulin A enriched polyclonal IVIG has shown possible efficacy, but the recommendation is against. Again, there have been some trials, large database from Eastern Europe, and it has been used for a significant number of years in that part of world. We also used in early 2000, but gradually we stopped using it. Again, this is the pediatric section which I am talking in this slide. For patients with toxic shock syndrome, especially those with streptococcal etiology, polyclonal IVIG may have clinical utility. Other potential pediatric populations that may benefit from IVIG in sepsis are those with necrotizing fasciitis, adults no support, and those with primary humoral immunodeficiencies or immunocompromised with documented low immunoglobulin levels. So, pediatrics necrotizing fasciitis or immune deficiencies is the only right window to use IVIG right now. Blood purification therapies. The largest amount of evidence as of today has been on polymyxin B hemoperfusion. The recommendations from surviving sepsis guidelines. For adult patients with sepsis or septic shock, we suggest against using polymyxin B hemoperfusion. There is insufficient evidence to make a recommendation on use of other blood purification therapies. This was the previous guidelines where they made no recommendation regarding use of blood purification technique, but 2021 they said against. Hyperglycemia. Stress, hyperglycemia, and insulin resistance are almost universal findings in sepsis patients. We all know this. Hyperglycemia is often pro-inflammatory and can impact the immune system. Conversely, there is oxidative stress also, and there are various mediators which drives hyperglycemia-induced immune dysfunction. Hyperglycemia can potentiate the pro-inflammatory response, while insulin has some immunomodulatory effect also. So keep this in mind, and hyperglycemia control is also an immunomodulatory strategy. Glycocalyx is the inner layer, forms the inner layer of the microvessels. Glycocalyx shedding is a feature of inflammation and sepsis. And if there is shedding of glycocalyx, this microcapillaries become leaky. And this is mediated by pro-inflammatory agent. So the role of human albumin in preserving glycocalyx integrity and microcirculation is being tried. Tight junctions, cytoskeletal, and antioxidative effect of albumin is what gives the advantage in terms of immunomodulation for albumin. The big question which we always are bothered is why and when we should commence these therapies, if at all, and which patient would benefit the most. Next 10 minutes, roughly 10 minutes or might be less, we'll be discussing on this. Judicious patient selection. Multimodal individualized approach is required. By multimodal, we mean several clinical and biochemical parameters are taken into account simultaneously. So don't just look at the clinical picture, also look at various biomediators, the hemodynamics, the oxygenation indices. By individualized, we mean refer to interpretation of changes in kinetics of certain parameters, such as PCT, rather than taking only fixed. So look at the biomarkers in a dynamic way. But monocausal therapies are not going to work. So targeting only one investigation or one clinical indices is not going to help. That is not the right approach. How should we guiding our therapy if we contemplate to use any of the immunomodulation? Guide to clinical status. The context is important. If your patient is improving, you need not add anything. The clinical response to the routine therapies, the physiology of the patient, how severe is sepsis, what is the risk of death despite the best interventions. This part of the talk is a little philosophical and has very limited science. I like to disclose at this point itself. But this is what helps us in deciding if we want to use any of these therapies, biomarkers, and the futility of care. If the care is futile and advanced disease, probably we should call it a day. But if the risk of death in a young patient, in a patient who might be salvageable is high, despite doing everything right, you might think about using. So you need to follow the surviving sepsis campaign guidelines and the good clinical practice for sepsis totally very religiously in each and every patient. Then the timing of disease is important. Neither too early. If we start using these therapies too early, we will never know the true benefit and the right subset of patient. A patient who is in slight septic shock, say map of 60, you give some fluids, the patient is bound to improve 90% of time. So do not use these therapies. And if it is too late, like a patient on norepinephrine and vasopressin high dose, you have already missed the bus. Early versus late, the debate is endless. The duration of many of these therapies depend on the response, on the degree of immune dysfunction. Although we use it for fixed duration earlier, the steroids or imlunostatin or other drugs, but this again has to be dynamic based on the disease. So we need to understand disease dynamics. Do we tend to use immunomodulation for severe infections, severe CAP? Yes, steroids is one, but not all severe infections per se. Selective severe infections, yes. All cases of sepsis, the answer is no. Septic shock, because the mortality is high, we tend to use some of these immunomodulatory therapies. Refractory shock, probably we have missed the bus. Infection-induced organ or system dysfunction as a cause of high risk of death is the single factor which pushes us towards using these therapies. Fully support the patient if you want to use any of these therapies. Apache score can help you. Apache's 2 score of more than 20, one organ failure, the second organ started to fail, but this is the right window. Apache 2 score of more than 20 although has a significant mortality. Sepsis-induced organ failure, septic shock, sepsis-induced ARDS, sepsis-induced DIC. Probably these patients had a higher mortality and we tend to use these therapies early. Subjective criteria will not help you much, but the objective criteria, various scores, will help you decide in the right context. The physiological parameters of the patient, the trends, and response to standard therapies. As the sepsis cascades to severity, these therapies also cascade from basic immunomodulation to selective immunomodulatory therapy or adjuvants for sepsis. To start at single organ dysfunction or two organ dysfunction, single organ dysfunction is sepsis as per the new definition. So once the second organ dysfunction is happening, the mortality is obviously going to be very, very high. If you think the patient can improve its standard of care, no requirement. If you think the patient can die, you can think about using therapy. Better to use it in experimental context and build some evidence. Already discussed earlier, we thought only this pro-inflammatory phase was the right window, but now we understand the anti-inflammatory phase is which kills more patient. So we tend to use in this. Syndromic recognition of high-risk patient, meningococcemia, sepsis-induced ARDS, sepsis-induced DIC, purpura fulminans, refractory shock. So what guide your therapy with patient to patients? All of that we have discussed. Can procalcitonin levels indicate the need for adjunctive therapy? We do not have a definitive immunometer for sepsis and will probably never have one. This is the benefit zone. Primary responder patients, they will have decreased kinetics of biomarkers with the good clinical practice, the routine sepsis care. No benefit from an adjuvant therapy. These are the early primary responders. On the contrary, non-responders already in refractory shock, probably you will earn bad name for therapy and add cost to therapy. It will become futile for that particular patient. While patients who have increasing PCT kinetics despite broad spectrum antibiotics and the routine sepsis care, this is probably the right window of opportunity and right benefit zone for these immunomodulatory therapies. Theranostics, we talk about biomediator level guided interventions. This drives us towards personalized medicine, biomediator quantification before and after therapy. Dynamic clinical and biomediator correlation are required. We cannot be driven only by dynamic hemodynamics or oxygenation indices or clinical parameters, but we have to look at both together. Timing of therapy already discussed. Sepsis that is inception is difficult to recognize but easy to treat. Left unattended, it becomes easy to recognize but difficult to treat. So if you want to use, do it in the right set of patient. Organ behavior is also a time function. All these immunomodulatory therapies tend to decrease organ dysfunction. What has been shown in almost all trials, the AKI rates are lesser. AKI recovery is better with most of these immunomodulatory therapies. And organ behavior is time function. If we want to use these therapies, use in the right patient. Some subset of patients, I think early, like decompensated patients, immunocompromised patients, risk of death by objective and subjective criteria, I think is too big. And the context of care is again very, very important. But this is a very, very personalized thing, and I will not recommend this. How early is too early and how late is too late, we have already discussed. We can go on a combinatorial approach, extracorporeal therapy with other immunomodulatory therapy. People have been doing it, but let us gather evidence for one at least before we start using it in a combination. What should be our expectation? What we tend to achieve is lesser degree of immune disarray. This should translate into improved microcirculation, which should further translate into improved hemodynamics, lesser MODS, and improved outcomes in terms of survival benefit. Is it asking for too much? Yes, we have been asking for too much. Are our endpoints in terms of mortality benefit 6 months or 1 month the right endpoints? The answer is probably no, especially in context of sepsis with shock, where already the mortality is too high, and it is very difficult even to prove that immunomodulation is happening only because of this single intervention. So we need to look at newer endpoints, soft endpoints, to give some space for these therapies to prove themselves. Survival advantage is probably not the right endpoint for vast majority of these immunomodulatory therapies. In the world of evidence-based medicines, adjunctive therapies have a very difficult task to prove themselves. Many single-centric or small studies showed therapeutic benefit, but these positive results are contradicted by large multi-center trials. Nevertheless, from a pathophysiological point of view, they have a firm physiological basis. So we need to look at this big data analytics with a different spectrum. Theranostic studies look at phenotypes and genomic groups of patients and search for better predictor outcome for these therapies. Difficult to attribute mortality benefit to a single therapy and remotely not to a single biomediator level. The level is coming down, so the patient is improving. Surrogate endpoints, we should have at least 1 month survival benefit or even tapering of vasopressors, ice to discharge. Monocausal therapies have always failed and they have failed us also. So we need to have realistic endpoints. We need to have multi-targeting endpoints for survival advantage and surrogate endpoints for 6 months mortality for these patients. We are looking at personalized immunotherapy. We need to look at various proteomics, transcriptomics, metabolomics, lab values, clinical picture, the physiological indices, while we tend to decide on the phenotype on patient. Then the phenotypic modeling of the patient will be done, and then the patient can only be identified on the basis of treatable trait, that which of this immunotherapy the patient can benefit in which phase of disease. The practice points from my talk: these immunomodulatory therapies have a firm physiological rationale. Good clinical practices in sepsis tend to do a lot of immunomodulation, especially enteral nutrition and steroids. The specific immunomodulatory therapies we must understand when, what, and how to use. We should be judicious, individualized, personalized with a dynamic view. We should be targeting phenotypes now. Endpoints have to be relooked. Further studies are required to expand our knowledge on novel indications. absence of evidence should not translate into evidence of absence. We need to decouple these RCTs. We should not be pushing these molecules by cult science or by publication pressure. This is how evidence should not evolve. And by asking for so much from single therapy, I think we are desiring too much. That will probably never happen. It's always the little things that make the big things happen. Same applies to ICU practice. Big things never work. Multiple small things which we do day in and out tend to improve outcome. Good, tender, loving care. And that goes with our theme. Every drop counts. Thank you, Hicks. Thank you.
Thank you, Yash, for the fantastic recap of what was, what is, what will be, and then what should be. Right? So, what I can say is the whole paradigm of success, you and me, and Ghanshyam, we all started our careers as trainees and then as consultants together maybe 23 years ago. Uh, it has changed a lot from the way what we were treating patients and how we were treating patients and what we were teaching our students on how to treat. So, but still, even today, we don't understand what sepsis is. Just to highlight one point, we know that sepsis is associated with DIC, but very few patients with septic DIC bleed. They have coagulation, they have thrombosis, they have other problems, but they rarely bleed to death, unlike a dengue patient, unlike a trauma patient, unlike a obstetric hemorrhage patient. So obviously, the pathophysiological mechanisms which cause the multi-organ failure are much more different than any other conditions which produce multi-organ failure. And as you said, it's going to be phenotypes. From from the bone criteria of fever, leukocytosis, respiratory alkalosis. From there, I think we are going to a system-based approach. The four phenotypes of sepsis: which organ system is predominant, therefore what strategy is going to work, is the way sepsis is going to be managed in future, and there is no magic bullet that's ever going to come, because this is such a varied and heterogeneous syndrome that no single drug intervention or concept or approach is going to be fitting into all the shoes. So, Ghanshyam, your comment?
Thank you, Yash. We all know that you are very passionate about sepsis per se and
But
its management.
still, I try to keep on time.
Yeah.
I was a little worried.
I think difficulty with respect to immunomodulation in patients with sepsis and septic shock is multifold. One, the heterogeneity of patients. No two sepsis patients are the same. Second, the timing of presentation, right? When does the sepsis actually start in a patient, and when do they present to us? The reason why probably whatever benefit we have seen in experimental models was never actually duplicated in clinical practice was that in experimental model, you were very, very sure about when the initiation of sepsis happens. But that was never kind of duplicated in a real life scenario, because you are never sure when actually sepsis was initiated or triggered. So you never know which phase of inflammatory response the patient was there. Third, I think, unlike other conditions, we do not have a measure of knowing what immune status the patient is. We absolutely don't have any way of measuring the immune status of a patient. And that I think is a major kind of limitation for all of us. And even if you're thinking of an immunomodulatory intervention, not everybody has all the interventions available with you. So you are going to do or use whichever is available with you. And to be very honest, most of us use these techniques in desperate situations. And we are using it in situations where the patient is deteriorating, where the patient is going into multi-organ dysfunction, where the patient is about to die. So maybe that's the reason why many a times we have very, very negative kind of a experience with these things. So I think, as you rightly said, if we can identify, or if we can kind of, as Srinivas said, phenotype them, and then look at some of these interventions, maybe we can get some answers. with respect to modulating the inflammatory response in sepsis. Otherwise, if we keep doing it blindly for all patients, I think we're just going to get more and more negative results.
Yeah, one last point, sorry. So as I made it very clear, we are not promulgating the use of any of these interventions. You are the best judge. And you have to look at the side effects also. The cure should not be worse than the disease. We have seen patients in refractory shock started on various extracorporeal therapy, the shock version, the patient succumbs. Same happened with Zygris. Many patients bled, the evidence was limited. So be very, very judicious while you choose any of these therapies, if at all. But the general interventions or immunomodulation, which should be done in all the patients. It costs nothing.
Thanks, Jeff.
Thank you. My pleasure.
We apologize for the technical
Not at all,
glitch we
happens.
faced. This is not in our hands though. There are multiple phenotypes of webinars, and this one has consistently stuck to its aim and its philosophies over the last 15 years. So sometimes roadblocks do happen, speed breakers do come. The solution is to slow down and cross the speed breaker, change gears, and that's all you can do.
Enjoy
So
the
those of you
journey.
who are
We need to
that's
enjoy
it.
the journey.
Honking at the speed breaker won't help. So, so for those of you who have any queries, comments, or clarifications, please do post them on the group from where you got this link from, and the moderator and the speaker will try to answer them at the earliest possible. Thank you all for joining on this sixth webinar. Please do join us again next week for another interesting talk on a contemporary topic in critical care. Thank you, Yash.
Thank you. Thank you, Dr.
Thank you.
Nishant. Thank you.